Hi, good morning. So my name is Linsey Blair. I'm a sex and relationship therapist working up in Galway. And I've been asked just to do a little recording about cancer and sexual intimacy. I mean, I think the first place to start, where I always tend to start with these, and excuse me, I am going to be sipping hot lemon through this because I lost my voice this morning. The place I always tend to start is just to talk about what's normal first, because I think there are a lot of myths around sex. And then what happens is we live by these myths. And when something goes wrong sexually, we start to believe that we are wrong. Yeah, as if the myth itself was a truth. So let me just talk about one of these myths. The biggest myth is around female desire model. So now we basically feel that there are two models of desire, the male model of desire and the female model of desire, and they are quite different. However, the widely accepted model of desire out there in the public is the male model of desire. Now, this looks like this. So the male model of desire goes, okay, so I get horny, that comes first. You feel desire first. Then what you do is you initiate sex. Then after the initiation, there's a buildup of arousal. And then you go to plateau, which is the bit before your orgasm. Then you go to orgasm, and then you go to resolution. Okay, so in that model, you start with the feeling that you want sex and everything else follows. Now, what we know from interviewing females is that many women actually do not start with that feeling of wanting sex. They start with a feeling of what we call now neutrality. Now, neutrality looks a bit like this. It looks like I could have sex, but I could also have a cup of tea. I could have sex, but I really want to watch this program on Netflix. All right. So sex has about as equal measure as everything else. It is as equal to doing the dishes. Okay. You kind of know that you kind of should be doing it, but you really couldn't be bothered. That as a starting point for a woman is normal. Okay. This is just simply to do with estrogen versus testosterone differences. Okay. And of course, it exists in the spectrum. So some women, depending on their testosterone levels, might be more in the male model. Some men will be more towards the female model. It's a vast spectrum. Now, then what happens with a woman is if you imagine that she's in a space of neutrality, she needs appropriate initiation in order to have sex. Now, if we're talking about a heterosexual relationship here, we're thinking about the male model versus the female model, the guys might start from a place of wanting sex. That means he tends to initiate in quite a forward way. That could be, grabbing your bum while you're doing the dishes, or going straight to the breasts, or going for the mouth to have a kiss straight away. Now, if you're in a space of neutrality in the female space, that often feels a bit shocking, yeah, because you're just not there yet. And so women tend to pull away at that point and reject, okay? So it's important to think with your partner about what appropriate stimuli is. For everybody, that's different. It could be sitting down having a chat. It could be him helping with the dishes. It could be pouring a glass of wine for yourself and just relaxing at the end of the day. You need a lead into sex, okay? When you have that lead in, then what happens for a woman is her body might start to kick in. So if you feel that you want sex, you're going to go there and then you start to say foreplay. And I really would encourage the foreplay to be slow and sensual, not straight to the genitals and breath. Slow, sensual foreplay to bring the woman in, to kind of pull her out of neutral. Okay. Her body will start to kick in. So her heart rate will go up. Her pupils will dilate. Her vagina might, depending what's going on with the vagina, the blood will flow into it. It might expand a little bit. The walls will start to have the cushiony effect. A lubricant will come. And she's still thinking about the dishes. Okay. So this is another interesting thing about the woman. Desire hasn't kicked in, even when the body has. All right. So we remain in a place of neutrality for quite some time into sex. That also means we're much more easily distracted by noises that a kid might make, or a sound outside, or a cat meowing, or whatever. We're much more aware of our surroundings because we're not quite in it. Okay. Then women as well go up to plateau, the body starts going, and just before the point of orgasm, quite high plateau at this stage, boom, you're in. Okay. That point, the woman wants sex. Her mind connects to her body and she's ready for the sexual interaction. So you can see the complete difference there. All right. Men tend to begin with desire, begin with horny, and women tend to almost end with desire. The problem is, if we're following these two models, and what has happened is the male model has tended to dominate, so people believe that's one. The male model that begins with desire is roughly, from beginning to end, erection, penetration, ejaculation. We could be talking 5, 6, 8 minutes, right? From the female model, because desire is at the end, it takes a long time to pull in. We could be talking 20 minutes. So a lot of the time, what happens is the female never gets to access her desire. Sex is over before she gets there. Okay. Then what happens is a woman is less likely to want to move out of neutrality the next time. Okay. Now I'm saying this now because what does happen is that during the woman's fertile periods, which is often a couple of 3 or 4 days, say a month, she will start to fall into the male model. Okay. So she gets basically more horny, and she will initiate sex at that stage and have spontaneous desire. Okay. Post-cancer treatment, what happens to a lot of women is the induced menopause. Now, post-menopause, obviously, if you don't have the fertile periods, you're not accessing that level of spontaneous arousal. And at that stage, women start to feel that there's something wrong with them. So they often present to me with a lack of desire, okay, feeling that they just don't want sex. In fact, what's happened is that spontaneous arousal they felt was the only kind of valid time. Does that make sense? It was the only time their arousal was validated, their sexual desire was validated in these 4 days because it matched their partner's cycle. That's when they initiated sex. All right. What we actually know from working with lesbian couples is that there are real issues often initiating sex because two people are in the state of neutral. And that's normal. Okay. So when these 4 kind of days of spontaneous arousal fall out, women start to feel like there's something wrong with them, but there isn't something wrong with them. Okay. You're just in a very normal, neutral place. What needs to happen now is the sexual script needs to change a bit. And actually, perhaps for the first time, the female cycle and the female arousal pathway might start to predominate in the relationship. Okay. It might get much more of a voice now than it ever had before. And that's really, really important. Equally, for men, a lot of men who've had hormone treatment start to enter the female model of desire, okay, because of the lowering of testosterone and the upping of the estrogen in the body. And they too then start to feel like there's something wrong with them, okay? It's a big, big, big step for men to go from having spontaneous arousal to being in a position of neutral. And it means they're simply going to have to work around this and more like the female model. And the female model basically means we have to draw out foreplay a lot in order to get the mind connected to the body. It is a lot slower in the female model. It takes a lot longer. All right. So that's the first thing I would like to clarify. Now, if we think a little bit about what is happening sexually, first, let's think a bit about what's happening sexually for women. Now, of course, there's a variety of different cancer treatments and surgeries and radiation surgery and brachytherapy that will have left all sorts of kind of scars with the body. One of them, which I mentioned, is the inducement of the menopause. Now, when the menopause is induced, it tends to be a lot harsher than when it happens naturally. 2 things happen quite fast. The vaginal walls will start to thin. And that can mean that they're not getting that kind of sponginess that they used to get. They become thinner. That means they're more prone to tearing a little in sex. That sounds terrible, tearing. It actually it just means you will probably have there aren't very many nerve endings in the vagina apart from in the inside of the clitoris and in the first third. So the tearing in the vagina walls isn't necessarily super painful. In fact, women might not notice it, but it will lead to blood during sex. Yeah. If there's scar tissue in there, it can be sore or rubbing, depending on where the scar tissue is. It's the first third of the vagina, like I said, that has the most nerve endings, where the internal clitoris is. So if this is all happening, then what we would recommend at this point is a really, really decent lubricant. There's a lot of lubricants out there. I would recommend getting some and trying them out. You can try them out on the inside of your arm. to test for any allergies. At the moment, sex therapists have been searching for a long time for a lubricant that matches the pH levels of the vagina. Because what can happen with lubricants is that if they're too wet and they don't absorb properly, then the vagina starts to compensate by drying itself out to try to reach a kind of pH level. And this movement from being too wet to too dry is kind of the perfect atmosphere for a fungal infection to grow. And so a lot of women using inappropriate lubricants will end up with reoccurrent thrush. Okay. And then they can get into the whole treatment of the caniston, which actually ends up leading to more thrush. So you need to find a lubricant that's absorbing well. At the moment, we're recommending a product called Yes. You can find it at www.yesyesYes.co.uk. In Ireland, they sell it in Holland and Barrett's. And there's water-based and oil-based. Their recommendation post-cancer is to mix the two or to stick with the oil. Okay. The oil is a lot thicker. It doesn't absorb quite as well as the vagina. It will leave kind of a shiny feel to it. Sorry, not as a vagina, as a water lubricant. It will leave quite a shiny feel to it. But just see what you're comfy with. If the walls are not spongy enough, the oil provides that kind of layer, that sort of barrier that the vagina is not really able to do anymore. The second thing that happens post-menopause with the hysterectomy or maybe the removal of breasts is the vagina will start to atrophy. Okay. This sounds a bit horrific. What you need to know is that the same thing actually happens in men when they get older as well. The penis will start to shrink a bit. The vagina starts to get smaller and almost start to begin to close in itself. Now, this naturally happens in postmenopausal women. It will just start to go smaller and smaller and smaller. But again, when the menopause is induced, that starts to happen faster. Now, if that's the case, your healthcare provider should probably have given you some dilators. Okay. There's two types of dilators on the market. The ones you were probably given are plastic ones by a company called Emil Comfort. They can be quite good if you have any vaginal scarring in the inside or pain. And what I would recommend is you can put those plastic ones in the freezer. Get them a little bit cold before you put them in. That will numb any of the pain areas. However, what we're pushing a little bit more now is the silicone type of vibrators. Sorry, dilators, not vibrators. They have a band in them. Okay. And you can buy them in sex shops like Love Honey and Joe Divine, both deliver, as far as I'm aware, free of charge to Ireland. They're a little bit less also clinical looking. They come in like multicolored packs, and each one has a different color, and they have a nice. Some of them also have a little space in the back that you can put a vibrating bullet. Really recommend vibrating bullets alongside the use of dilators, because what they can do if you hold them in the internal bit is they'll help relax the pelvic floor. Okay. When you use the dilators, you need to use them in a mindful way. Okay. So I would recommend not just trying to kind of shove them in while you're watching some horrific program on Netflix, but try to do them in a relaxed place, like maybe in the bath, first of all, when your muscles are naturally relaxed. You're going to put a little bit in, this much, using the first dilator, which is probably about the size of your little finger, and then it goes up to tampon size. You put a little bit of it, a little bit of dilator in the vagina on the exhale breath. Pay attention to your core. What women tend to do if there's any sexual pain or vaginal atrophy or the vagina is uncomfy is that at the point of penetration, they take a very deep breath unconsciously in, and they pull in their stomach, kind of like that Pilates move of when you really hold your core tight. Now, what's happening then is the pelvic floor, which is a muscle that crosses through the vagina. It's a muscle that you kind of pull in to stop yourself farting. That's the same muscle that can close over the vagina, same muscle that's responsible in men and women for the orgasm, the kind of release, the pumping of it. So if you're taking that breath in at point of penetration, it's almost like you're expecting pain. It's like the brace position. Then the pelvic floor will close over slightly. The muscles in the vagina will close, and that will make penile entry a lot more hard, all right? Difficult to get in. So you need to be careful when you're using the dilators to make sure it's on an exhale breath and your tummy is relaxed. Twist it. That will again help the muscle relax. And then put it in a little bit. Breathe, twist until it goes all the way in, and then try to rest it in for a few minutes. Then you move up the level slowly, slowly, always starting with the one before that you completed. I usually get women to do it in a couple of positions, lying down in the bath, standing, tampon position, and then missionary position on the bed, or also called smear position. When you've done 1 of 3 positions, like, you can move on to the next one, okay? Or skip a position if it's really like sore or hard. You have to be flexible with yourself. A lot of people feel when they get up to number 4, same size of penis, they're done, and they can zip up the vagina dilator box and put it all away. Unfortunately, that's not the case. This will be a constant battle against atrophy that all women need to be aware of when they're pushed into the postmenopausal position. You have to continually be having sex or using the dilators in order to keep the vagina open like that, which is difficult. And that's why I would really encourage you to use the dilators in a pleasurable sense. So if you do get up to number 4, what I would do is buy a vibrator, same size as number 4, and just use a vibrator in masturbation. Yeah, and you can do that more regularly than you might be having sex with your partner, and it's easier to do in terms of the access and the time. So that's a nice way to keep the vagina open. All right. Of course, one of the other changes people encounter is bodily changes. You might have lost a breast. There might be scarring. There could even be a stoma bag. A lot of these things make our body feel very different to us. What I would recommend you do then is, and this is hard, try to sit and rest with the space that you're most uncomfortable with. So I often set a bit of an exercise for women in the bath. It's called self-focus. And it goes like this. So you're lying in the bath, make the bath nice for yourself, put on music, put bubbles in the bath, make it a good space. And all I want you to do then is really gently touch your body. Starts off the top of your head and just starts moving down your face. And all you're trying to do is connect back in with your body. What you need to remember is that after any illness and any hospitalization, your body has lost a lot of its feeling of being an erotic center, obviously, but also being a kind of center that any pleasure comes from, any pleasurable touch comes from. There's a lot of power that gets lost in any hospitalizations and treatment as well. Your body gets taken over by other people. And so you really start to disconnect with it as a form of self-defense, all right? If you cannot speak up for your body and you cannot say no because you feel you have to do these things, then the best defense is almost to disconnect from your body, hand it over to the medical profession. This sense of disconnect can really remain after cancer, almost like you become a bit of a stranger to yourself. This touching exercises is to help you connect back in. This is my body. I understand what it's been through. I need to re-find it again. I need to reclaim it. And I need to take some of that power that was taken away from me back. Okay. Very softly stroking yourself, just trying to connect in and check out what's going on for your body. Okay. You've been traumatized and it's been traumatized. A lot of its muscles will probably be in brace position without you even knowing it. It's going to be holding itself quite tight, like a little bit of flight response, waiting for something bad to happen. So keep trying to relax all the muscles. The tighter you hold the body, the more adrenaline will be in your system, and the worse that is for your immunity. If we stay in fight and flight, our body's kind of constantly fighting, and so we end up getting increasingly tighter and sometimes burn out, get more viruses, without us even knowing that this is what's happening. So keep trying to relax yourself. Now, in terms of the bodily changes, if there's been something happen, like say you've lost a breast or had breast surgery, I would really stay with that point that you're not feeling very comfy with. Rest your hand on the scar, shut your eyes, and see what it feels like to sit there. Okay? This is about trying to stay in touch with what you've lost. Okay? That's a really important part of cancer. There is an idea that, I guess, when you're well, you just get up as if you were never ill and start going again. That's kind of skipping over the morning. It has to be morning in order for us to move on properly. Now, morning doesn't have to be devastating. It doesn't have to be like you find that spot and you start crying and you're never going to stop. You will always stop crying. But what the crying does for everybody is it allows for more joy. If we skip over that period, we're going to stay in that disconnected place. All right. So morning is a way to move on. That's true for your partner as well. A lot of partners, people who've had cancer, often say to them, it makes no difference to me, that scar. It makes no difference to me that your breasts are different sizes. It makes no difference to me. Now, the truth is, it does make a difference to them. You know, it's almost a bit insulting to think it doesn't. We love our partner's bodies. They are familiar to us. And if their bodies change, we're obviously going to experience some slight discomfort with that. I think partners think that's the appropriate thing to say. Whereas in fact, when they come to me for a couple therapy, I encourage them both to acknowledge that there have been changes and that these changes are difficult and that they have to kind of say goodbye to the old body. It's okay to say to your partner, I really miss your other breast, because you miss it too. And you can sit there and say, yeah, I miss it too. Let's think about what we have. A lot of time there might be a loss of sensitivity in certain areas, a loss of sensitivity in the breast, a loss of sensitivity around the vagina. That simply means you got to rewrite the sexual script a bit. Erogenous zones shift and change all the time. So you have to find out where they are now. That's good. That means you open up the whole of the body back into sex. What I get couples to do is kind of go back as if they were a courting couple, right? And I mean a courting couple in the olden days, because I think couples go quite fast to sex now. So I ask them to park genitals and breasts. So in the early exercises, both women and men would keep on their underwear. And what I might say is, look, just touch around those areas and try to find other areas in the body that are pleasure centers. The ears are one, the lips, the feet. A lot of parts of the body have a load behind the back of the knees in here. Lots and lots of nerve endings. And they can also act as erogenous zones. When the bits that you were used to going straight to in your sexual script are not working in the same way. So what I get couples to do is really, really play with the whole body. Okay. I might say, look, touch your partner for 15 minutes all over in the front and all over in the back. And then you swap. They touch you for 15 minutes all over in the front, all over in the back. So that would be an hour in total. And then you just lie in a silent hug. Then every so often in every exercise, and this is called the sensate focus model that psychosexual therapists use, in every exercise, we might turn up the dial just a little bit. And when we turn up that dial, you might start to include other bits. I mean, I might include the mouth first. I might bring in massage oil, still leaving out whatever the site is of discomfort and pain, you know, really including the rest of the body, really getting the partner involved. A lot of people say to me, my partner really misses sex. From my experience of working with couples, partners really miss touch, not sex. And it's important to widen the definition of sex at this point. So that includes all sorts of touch. Sex does not have to end in penetration and orgasm. All right. That is a myth. And it's a myth that people need to stop following, because it really reduces sexual potential. Okay. If we are focusing on penetration, like I said, sex is no longer than 10 minutes max. You can have sex. You can play for an hour. Yeah. Including your whole body, not even touching the genitals, you can play. And that will give you a sense of intimacy. Penetration, orgasm, it's not necessarily where intimacy lies. And from my experience, partners crave intimacy more than sex. So that is what we try to recreate. Now, if you want to move on to penetration, you can. But I would try to have it there as a dessert rather than the main meal. We really encourage people to start getting full up on the whole body, so that if you're in a place, say, where there's a very sore vagina, or you've had a few leaks that day, you're around like incontinence, and you just do not want that area to be touched, that's okay, because you can fill up on the rest. All right. And you and your partner will still have an intimate and connected experience. I'm just going to share my slides with you so you can see some of the things I've been talking about. Some of the little pictures here. Okay, so those there, here we go. Those are the dilators I was talking about, the silicone dilators. Here we have the O-nut. Now the O-nut is important if there has been any shortening of the vagina. So what we do, and this is again in a heterosexual relationship, is these little rings go on the end of the penis, and it basically reduces the length of the penis to the same length of the vagina. All right. Some women do not realize that the vagina has been drastically shortened. So I'd really recommend that you go to a pelvic health physio perhaps, or your GP, just to get that checked out if the penis is not going in Could be vaginismus, which is a tightening of the pelvic floor, but could also be that some scar tissue has formed and actually shortened the vagina. So do get that looked at. Here we also have an ERIS device. This is again post-menopause and extra dramatic menopause. If the blood is not flowing properly into the genital area, this is like the vacuum pump for women. You put it over the clitoris and it turns on and it pumps up the clitoris so you can have the clitoral orgasms. These are the anal plugs that you can put in during sex if you're worried at all about leakage or incontinence. And here is, you can see this one, but that is the pH of the lubricants available. And as you can see there, yes, silk's at the end. You're often given silk by your GP. There's yes and silk are the ones that we would tend to stick to, but you need to try them, okay, to know what will suit you. I'll just stop sharing this. Okay, and now what I'm going to do, and we chatted a little bit about women, is go on and think a little bit about what's going on for men. Now, as I spoke of before, we have those two different desire models, so the male one and the female one. And as I said before, and it's worth even, listening to this if you are a woman with cancer in a heterosexual relationship, because some of what I'm going to talk about now is just about the experience that men go in, and some of what men might experience as well if their female's partner's bodies changes. So as I was saying earlier, you get those two models of desire, and sometimes the male, because of estrogen treatment, will end up entering more of the female model of desire space. Okay, and again, what that means is just that sex simply has to be slower and you have to initiate it in different ways. If that's happened to your partner, it does not mean that they do not desire you. It means they're in a different model of desire. Okay, so that means for men as well, sex needs to be slightly slower and more sensual. And that sensate model that I spoke to you about, really slowing it down, spending time in the rest of the body, that is also really appropriate for men. Now, what could happen with men in prostate cancer is that there's been maybe, again, that difference, like the female breast, there could have been removal of the testes, or there might have been shortening of the penis. There might be damage to the nerve endings, which means that erections are very, very difficult. They might be completely impossible. There might be no ejaculation, or even sometimes premature ejaculation. And so the male system has changed dramatically too. I mean, you need to find out from your doctors, first of all, if the problems you're experiencing with your penis are physiological or psychological. There's often an overlap between the two. If it's physiological, you're going to be given probably some, there's a vacuum pump, there's the penile implants. These are things that will help you get the erection when it's a physiological problem. If it's psychological, they often will give Viagra and Cialis actually as well. But they usually say, listen, just give it some time and the erection should come back. Okay, it doesn't seem to be a physical problem. It seems to be something psychological. Now, what's really important to realize is that the psychological problem around getting and maintaining the erection is simply anxiety. Okay, so when you give somebody Viagra and Cialis, they often don't work if you're anxious. And the reason that they don't work if you're anxious is simply that a part of anxiety is in a bodily aroused state. So as in when we're anxious, our heart beats faster and our pupils dilate, right? So a lot of this is actually like sexual arousal. So what Viagra and Cialis does is they put a wee bit of pressure on the heart, and so the heart starts to pump a bit faster to pump more blood in the body and push blood basically into the genital area. But if you're anxious about not getting the erection, if you're worried that it's going to be a catastrophe and it's all going to go wrong, then you can interpret this slight raise in heartbeat incorrectly. It's pushing for a sexual arousal, but you can go by, oh my God, I'm going to have a panic attack. This is dreadful. And so sometimes you get more anxious with the Viagra. Now, if you get more anxious with that, you tend not to be able to get the erection because anxiety cuts across the desire pathway in men. bit different in women, but in men, the anxiety can cut across the desire pathway and actually not allow you to get the erection, because you start going into fight and flight. There's no need for an erection when that's happening. All right. So just be aware that just because Viagra and Cialis isn't working, it does not mean that the problem is forever or physiological. Okay. Sometimes Viagra and Cialis will work with anxiety because they act as a placebo. If you are confident enough that they're going to work, they tend to work. All right. Now, if I just talk a little bit about that, what we call the circle of failure, which is often what happens to men with ED. Now, if you're a female, being erectile disorder. Now, if you're a woman still listening, say, who went through cancer treatment, what you can often see is that the partner starts to experience erectile disorder as well, as a response sometimes to the pain that the woman's in, or the discomfort she feels in her body, or his own discomfort at her bodily changes. And so this circle of failure is a really important one for partners to be aware of. Now, a circle of failure looks a little bit like this. All right. So you start in sex. Okay. You initiate sex. Now, for men, this is different, depending on the individual. Some men can think, oh God, we're going to have sex on Saturday. And by the Wednesday, they can start freaking out about the fact they might not get an erection. Oh my God, what if we don't get the erection again? What if we're just lying there? What if we have another argument? What if the Viagra doesn't work? What if she doesn't want it? I'm not taking the Viagra. So even on Wednesday, they can start to kind of panic about what's going to happen. For other men, they're absolutely fine until sex starts to be initiated and the kissing and touching starting, and then they start to panic about whether or not they're going to get erection. Either way, what happens is you tend to be in sex with slightly raised levels of anxiety. This makes it very hard to stay in your body. Now, the same thing happens, of course, if there's any sexual pain or anything. All the things going on for the female as well. You find it really hard to stay in your body. You start worrying about when it's going to go wrong. Now, if it's just worrying about when it's going to go wrong, then it's incredibly hard to get aroused, okay? Sexually aroused, because you're not relaxed. So it means sex tends to look like two people are going through the motions, but they're not actually aroused at all. They're often worrying about what's going to happen next. Now, in the case of erectile disorder, this means the partners tend to be doing something I call penis watching, which means that they're in sex, but they're thinking about the penis. They're going, oh God, why is my penis not hard? Usually when she does this, my penis is hard. This is going to be a disaster. Da, 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 da. Often the partner's thinking the same thing, or thinking, oh my God, he's not thinking about me. He's just thinking about his penis. And then they start thinking about his penis. Oh my God, it's not hard. We're going to have that conversation again. And so sex is just simply completely unsexy. And if everybody's watching the poor penis, well, it's getting really nervous. All right. It's not sexy for it being stared at. Okay. And so what tends to happen then as well is blood will start to flow. Naturally, blood starts to flow when you're anxious. So the penis might get a little bit hard, like say a semi, and then suddenly everybody jumps in. You're like, oh my God, let's use it. There's an erection. Go, 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 go. So there's a massive rush then to penetration. What is really important to do is that this first initial little bit of an erection is probably just blood flow. It's not arousal. Nobody's aroused in this sex. So when you go on it and you try to push this penis into the vagina, what's going to happen is the erection's going to go. Usually on entry or just after entry. And that's not because, okay, you have problems getting erection. That's because everybody's jumped on the penis before it was even properly aroused. What I would really encourage a couple to practice, right? And I would encourage them to practice it with underwear on first, just like those sensory focus exercises I was talking about. So wear the boxers, all right? And just practice concentrating the whole body and seeing what happens to the erection, not thinking about it, thinking about yourself, okay? Thinking about your partner, thinking about enjoying the body, thinking about playing. Take out penetration. No pressure to penetrate at this point. Don't take Viagra or Cialis. Just play, right? And then afterwards, you can think about what happened. Did I get a semi then? Did I get no erection? Did I get a full erection? Do not use the erection, all right? If you get an erection in these exercises, just let it go. I would really encourage men to practice letting their erection go. You can do this by yourself as well in masturbation, and it's called wax and wane. So you bring on the erection. Yeah, see if you can get it right up to number 10 being fully hard, 0 being flaccid. See if you can get it up to number 10. If you can't, that's okay. Just see where you can get it to, and then let it go completely. Bring it back again, let it go completely, bring it back again, and the third time you can ejaculate the orgasm. This is an exercise so you understand what's actually happening with your penis, right? Can you get the erection? How is the blood flow? What number can I get to? Is that hard enough to penetrate? It also helps men realize that it's not a catastrophe if the erection goes. In fact, if we are doing good foreplay, okay, and I would say good foreplay, concentrating the whole body, about 15, 20 minutes here, the erection should be coming and going, all right? Another myth around sex is that the erection comes and stays fully hard through the whole of foreplay. No, it doesn't. You have to touch the erection in order for the penis, for it to get erect, to encourage the blood into it. So say if you're concentrating on a female body, right, and the female isn't touching you, she's in a more passive position, then the erection's naturally going to go down. The erection will go down again. That's normal. I would expect the erection to come and go roughly three, maybe 4 times in sex. And when you get more aroused in the foreplay, you'll notice the erections, instead of getting softer as they come and go, will get harder. All right. And so I would recommend to men to really forget the first 2 erections and try to concentrate on the third, because usually the first ones are used either because we're following a very old, young model, that model I talked about before, or because there's a lot of anxiety and everyone's jumping on the erection. All right. So just give it some time, okay, and let it come and go. If I just share the slides with you, you can see some of the things that are available for men as well in terms of the vacuum pump. A lot of men report difficulties around the vacuum pump. What I would recommend in terms of those difficulties is a vacuum pump. That's all in Mumford, but they have them in Medicare in Ireland. So Medicare are also selling these, and they're selling stuff for delayed ejaculation and premature ejaculation too at the moment. And they told me recently that they're willing to go out to people's houses to demonstrate how to use them. And they were also saying to me that the best way to get these to use is to shave off all the pubic hair and put Vaseline around the outside. And this creates a kind of more of a vacuum. Really, the vacuum pump will work. All right. It's clumsy, I know, but it will work. If it's not working, it's because there's air getting in. So the Vaseline will help block off that air, the kind of space between when you're holding it. Now, in terms of these tools, and again, this is true for the female tools as well, like the ONAT and the dilator. People tend to say, look, I don't want to use these tools. Those are the penile implants, well, the surgical one. They tend to say, I don't want to use these tools because they're so clumsy. They ruin sex. Sex becomes clinical. I would really have these tools there as play, okay? They can't be brought into the sex as, oh my God, now we've got to use a vacuum pump, all right? I would put them on the bedside table with a range of other things, all right? Whatever that might be. Oil, nice oil, chocolate spread, the decent lubricant, a glass of wine, whatever you want. Everything's there on a table to help you play around sex. Use it more as a toy than anything else, okay? So get your partner to practice and having a laugh with it. Don't make everything very, very serious in sex, all right? You get your partner to play with the vacuum pump and see who can get it working and see who can get it hard enough, and make it into a little bit of a game, okay? Have a bit of a laugh with it if you can. When there's kind of a heaviness when these tools got brought in and a sort of sadness, it says to me that something hasn't been processed with the couple as well around the emotional response to cancer. The couple probably have to do a bit of mourning together, all right? That what they have lost with those spontaneous erections, but this is what they've now got. But they have to say goodbye to what was in order to welcome in some new things within a sexual relationship. So I think there I've covered quite a bit of female and then a little bit of male issues that occur after cancer, mostly focusing on the erection. For men, I would also say if there's been changes in their body, maybe even some growth of breast, like I said, the shortening of the penis, removal of the testes, it's the same self-focus exercise that I was talking about earlier on for women. Really, really try to stay with the body, slowly and softly touching yourself and resting your hand on those areas that you feel have gone through the changes, right? To encourage some emotion to come up. Then go with your partner and you do the same touching exercises. The same thing around leaving penetration to a dessert. If there are any issues with penetration, or you're worried about the penis, or it's not going to work, or you're not going to ejaculate, for a while, just take it out, concentrate on the rest of the body. You will have a lot of erogenous zones in there. Find them, play with them, reconnect in, and then very slowly bring back the genitals. But I would also bring back the genitals, exploring them first, touching, playing, whatever you want to do with them, having a bit of fun before you attempt penetration. This is also the time for couples when there's been changes to bring in some new sexual practices that maybe you didn't do before, or get some back that you lost. You know, often in the kind of when couples first meet, they're doing a whole range of activities, and then it becomes much, much, much more functional as the relationship goes on. Bring back that range. Talk about what you used to do. Bring back oral sex. Yeah. Bring back full body kissing. Bring back different positions, perhaps. There's lots of different things partners can try. The full body sensual massage where you straddle your partner is a nice place to begin as well. Go on sex shops, find sex toys, yeah, to bring in a bit of spice. They're not all like hen party, fizz, crazy, you know, straw shaped like willies. There's actually some really, really good stuff out there now. So look online together with a glass of wine at the sex shops and buy each other something. Buy something for yourself, something for your partner. Like I said, the bullets are really good, the little vibrating bullets. They can be used on women and men. And then have those on your bedside table along with whatever, the vacuum pump, the dilators, the ONAT. Have that there too. So that there's a lot of toys, all right? I know it's hard because there's been a lot of loss, okay? But the hope is that you can create something new from this space, right? A new sexual relationship that might even be more satisfying to you than the one that has gone. I know it might sound unbelievable now, but after sex therapy, a lot of partners post-cancer report a better sexual relationship than the sexual relationship they had before, which tended to be functional, a rush to penetration. For the woman, they may not have very rarely been even having an orgasm. Sex was very quick. There wasn't much foreplay. And now you got to rewrite the script to include the whole body and lots of foreplay. It's actually a much more sensual and intimate experience. What I often say is that the sex pre-cancer tends to become a little bit idealized. Everybody wants to go back there. You can't go back there. So you need to go somewhere else. But maybe the somewhere else that you do go might be more rewarding and more fulfilling than the place that you left behind. Okay, it's a pleasure to talk to you all. And I hope you enjoyed this talk. And I will leave it over to Cancer Care West to distribute it out. Okay, nice to see you.